Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960. So I saw a report last week that I thought was kind of interesting. U of T has just appointed the first chairman of neurosurgery that is female, and she has an unbelievably impressive background. It's Dr. Zadeh. She's the head of the Division of Surgical Oncology for the Department of Surgery at UHN. She's the interim head Department of Neurosurgery at the Toronto Western Hospital. She's a professor of surgery at the University of Toronto. She's the medical co-director of the Crombie Brain Institute. She's the chair of the Wilkins Family Brain Tumor Institute. She's a co-director of the Elizabeth Robb Neurofibromatosis Program, whatever that is. She's a director of the CNS biobanking, and she's just been appointed as the first chair of neurosurgery at U of T. Dr. Zadeh, welcome to our show. How are you?
Thank you. Thank you for inviting me to the show.
So you were telling me just before we got started that there aren't that many female neurosurgeons.
Correct. So although more and more women go into medicine, equal number, if not more, females go into medicine. The field of neurosurgery still remains low in numbers for women. Less than 6% are women, and less than 1% are academic neurosurgeons, meaning have an appointment at a university. And so in general, having a leadership role by a woman in neurosurgery is very far and few. In North America and in Canada, I would be the first person, which is really a great honor for me to have this opportunity. When I look to North America, there's perhaps 3 other women who lead a neurosurgery program in North America. And so it's really an exciting opportunity. And I look forward to what I can do, and hopefully I can live up to the expectations that the role brings.
Well, congratulations for your appointment, and I'm sure it's well-deserved. I understand that you specialize in neuro-oncology. What is neuro-oncology?
Neuro-oncology is the management, the care for patients who have brain tumors. And we have a wide range of brain tumors. Some could be malignant, cancerous. Some are very benign. And in particular, in the case of benign tumors, surgery is really curative. And so the outcome for the patient is a positive one. It's a curative procedure, and it's really rewarding for us as surgeons to be involved. And those are tumors that occur in the skull base, which is the type of surgery that I do. And they're typically tumors such as meningiomas, pituitary tumors, etc. They're benign tumors. The cancerous tumors, surgery is required and necessary, and then patients then have chemoradiation to follow it. And that's the area we do a lot of research on to be able to help improve the outcome for patients with malignant cancerous type growths in the brain.
And is malignant cancerous type growths, is that glioblastoma?
Glioblastoma is the most common, it's the most recognized, and unfortunately, it's the most lethal cancer in adulthood of all cancers, where from the time of diagnosis, you have an approximate average 18 months to live, and then the tumor recurs, and unfortunately, we have no cure at the time of recurrence.
We're chatting tonight with Dr. Zadeh, just recently appointed chair of the Department of Neurosurgery at U of T. Incredibly impressive background. We're going to take a quick break and come back and find out more about what's happening in the brain, particularly with brain tumors and surgery. Stay with us. Welcome back. Here we are with Dr. Zadeh, the recently appointed chair of neurosurgery at the U of T. And I was just asking you, I apologize, are we going to call you doctor or professor or chair?
I would say Dan, chair and head of neurosurgery at University of Toronto. This is the position that's most noteworthy for me, and that's the highest position that I would want to hold, and that's the title I would go with.
Excellent. Well, Dan, chair of neurosurgery at University of Toronto. Tell us sort of where cutting edge research is into tumors in the brain, if you could.
So looking at the genetic changes that happen, genomic analysis of brain tumors is the cutting edge, and understanding why the genes have changed so that we can use that to our advantage to identify treatments. And then also be able to use that information to understand how the tumor reacts to treatment. So when the tumor recurs, has it picked up new genetic mutations? So mutations are changes that happen in genes that make them go from a normal state to an abnormal state, and that's why the tumor forms. And so understanding that would be the cutting edge, and also being able to come up with treatments that target that mutation, that alterations that happen. And much of the research we do in the lab, yes, focuses on this.
Now, I understand that you're also doing some research in regards to brain bone marrow derived cells in supporting a tumor in glioblastoma. I actually saw a TED talk that was bragging about the benefit of using bone marrows. Tell me what you're doing with bone marrows, if you could.
So when a tumor grows, it requires blood vessel and its own blood supply. And it's thought that if we're able to stop the blood vessels, then you stop feeding the tumor and the growth of the tumor as a result. And mechanisms that can stop blood vessel from forming would be to take away the molecule, the factor that the tumor signals for new blood vessels to form. And one of the factors that help towards blood vessel formation is that it signals our own body's bone marrow cells to come to the tumor and help build the blood vessels. And so if we can reprogram the bone marrow cells to fight against the tumor, we could potentially stop the blood flow to the tumor and kill it. And so really in very broad terms, that's what the research focuses on. Understanding how are the bone marrow in our body being reprogrammed to help a tumor grow, and how can we use that to our advantage to be able to stop the blood flow to the tumor and kill the tumor as a result.
So are you taking bone marrow from somewhere else in the body and putting it into the brain?
So in the experimental models that we do, we take bone marrow from one particular animal and put it in another, but it's bone marrow that's been reprogrammed to attack the tumor cells. And so yes, to some extent that's the case, with ultimately in clinical use, reprogramming your own bone marrows to be able to attack the tumor.
Unbelievable. And so it's not our own bone marrow, it's bone marrow from some other animal that you would be putting into the brain.
In the case of for human treatment, it would be your own bone marrow cells, but they would be reprogrammed. So they would be genetically re-engineered so that they actually go to the tumor and then start targeting the blood vessel.
Unbelievable. Sounds fascinating. So tell me a little bit about your background. How did you become the Dan Chair of neurosurgery at U of T? What were the steps that it took for you to achieve such a incredible honor?
So the steps were going back to from high school. I was really wanting to be a mathematician. I had one professor at University of Manitoba that made me realize perhaps this is not the field for me. And then I had two very good friends from medical school or from high school who told me to write the MCAT. And I wrote the MCAT, I got into medical school, and then I thought I would really like to learn neurology and learn about the brain and the brain anatomy. And from there, I was exposed to very early on in medical school neurosurgery. And neurosurgery was amazing and fascinating to me. The first operation that I saw was with a surgeon who is a great mentor and a great role model. And I really thought this is the field that I want to get into. He was very inspiring. He was very kind to his patients, a great teacher, very patient, and overall an excellent role model and a mentor. And so he really, and his name is Michael West, he's in Winnipeg, Manitoba. He really got me interested in the field. And then the other neurosurgeons at the time were very encouraging of me to go into neurosurgery because they said that we need more women in the field and we need to change the face of the field. So that's how I got into neurosurgery. And then when I moved on in my training, I really wanted to pursue a PhD and get a second degree where I would learn about genomics, molecular techniques, and tumor biology. And I moved to Toronto. And there again, I had a number of key mentors. Jim Rutka, who is the head of Department of Surgery currently, Ab Guha, my PhD supervisor, who unfortunately passed on, and a number of other key members really showed me what it would be like to be a true academic, scholarly neurosurgeon. And I remember when I met Jim Rutka, I thought, this is who I want to be when I grow up. And he was the Dan chair at the time. And so I really
so you've grown up.
That I would, pardon?
So you've grown up.
So that's right. So I've grown up and I've become the Dan chair because he, again, is much like Michael West. He's an amazing person. He's extremely kind. He's very thoughtful, an excellent surgeon, very, very considerate, and a trailblazer and at the forefront of the field. And so an excellent teacher. And so he really also served as a great role model for me.
Now you got your medical degree.
I've had a number of other people along the course of my career, and really working towards this scholastic neurosurgical career has been my goal, to be able to change the field and improve what we do for our patients is what drives me.
Now you got your medical degree in 1996, and then you got your PhD in 2006. So only 14 years ago. Is it unusual to go from getting a PhD in 2006 and then 14 years later become the chair of the department? That's pretty fast, is it not?
Perhaps a bit faster than average, correct. But I have to say, I give credit to the environment that I've been. University of Toronto is a very rich environment. I lived and worked in London, England for a couple of years. I recognized the strength that University of Toronto had, and in particular, where I work at University Health Network, at the Crombie Brain Institute, where, as you know, I'm the co-director, the Princess Margaret Cancer Research Center, where my lab is. It's really an unparalleled, unbeatable environment to be able to build the academic career and portfolio that you want. And I think I have to give recognition and consideration to the opportunities that it's brought to allow this maybe a more rapid than average course to getting to be the Dan chair. Yes.
My best friend passed away of glioblastoma recently, and it was probably about 18 months from diagnosis to death. And he had a surgery where part of the tumor or all the tumor, I don't know, was.
To hear that.
What do you think the future is for glioblastoma?
Yes. Yeah, I'm sorry to hear that. It is really, it's a devastating disease, and I think an incremental change is a positive change. I think that any impact that we can have to change the course for the patients, not just the outcome, but really the impact it has on the person as an individual, as to who they are, their emotional status, their quality of life, their functional status. Those are equally important as being able to improve outcome with regards to longevity. Because, and I don't know the particular case for your friend and colleague, but I think it affects so many aspects of the brain, and the brain makes us who we are. It's really sad to watch people go through this illness, because they often change as who they are as people, and their themselves, their family, their friends, their loved ones really go through a very difficult process in coming to terms with the diagnosis and then living with this cancer, be with them, to be able to live with this tumor and to be with that person. So I think even an incremental change in increasing longevity, but more importantly, changing the experience for the patient is really quite important.
Is COVID-19 impacting your practice at all?
It certainly has. It's impacted our ability to have in-person appointments, which to me carries a lot of weight. I like to see the person in front of me to be able to make the eye contact, to have presence with them. But at the same time, it's also showed that for some routine visits, avoiding having to bring everybody downtown is good. It also has changed our considerations early on when we didn't understand COVID and what precautions we needed to be put in place as to the impact on the disease. But certainly today we know more than we did 4 or 5 months ago, and we're much better prepared to manage the patients and the volumes that we need to as they come to us. And so I would say we're back to a baseline of being able to offer treatment. But in the early days, because of the uncertainty and the unknown, and not having all of the resources necessary upfront, there was a little bit of a setback, yes. But today, I would say with the precautions, we're back to where we were and being able to treat patients with brain tumors.
We've been hearing a lot about cognitive impacts from COVID-19, where COVID-19, from what I understand, is impacting the vascular system, not just the respiratory system, and via the vascular system, it's impacting the brain. Are you worried about that at all?
We certainly see a much higher number of people who have bleeding into the brain because of what you just mentioned very, very correctly, the effect on the vasculature of the brain. We don't have a good sense about it. I don't think we have the correct percentages for me to give you an accurate number. And then keeping in mind that obviously I only see those who have blood in their brain, so I don't have the full picture. But it does certainly increase the risk of bleeding into the brain or strokes of the brain. And we're seeing more of that. And I think it is very correctly, as you said, because it affects the vasculature of our whole body system. And then our brain is more vulnerable with regards to being impacted by the vasculature.
What's the most interesting or challenging case that you've been involved in?
For me, the most challenging cases are the skull-based cases where a nerve, the nerves that we call cranial nerves, are involved. So tumors that come from cranial nerves, because our cranial nerves come out of our skull base and allow function within our head and neck, which are critical. Closing our eyes, speaking, moving our tongue, swallowing, the ability to talk. It's really essential functions. And when there's a tumor that comes from that cranial nerve, the dissection of the tumor, separating the tumor away from the nerve under the microscope, is one of the most intricate surgical techniques. And it's challenging and it requires a considerable amount of focus, and the stakes are high because if the nerve is damaged in the process of separating out from the tumor, the loss of function comes at a very high cost to the patient. And so those are the most technically challenging, and also the responsibility of managing that operation to come through with minimal to no deficits is quite high. So those would be the most challenging cases. Some of the other scenarios are more challenging in the manner that the tumor affects the patient, which we talked about earlier. The extreme malignant tumor, where it robs the person of their life in a short time, that I think is always a huge challenge from an emotional perspective, because you form a bond with the patient, and to see them rapidly decline and die of that cancer is one of the most devastating experiences we go through, I would say.
Doctor, really appreciate your time. You're obviously incredibly successful at a reasonably young age, 14 years from your PhD to being the Dan Chair of Neurosurgery at U of T. If there's any young females listening to our show tonight, what's your message to them?
My message would be to, I would say, females and males, if there's something you're passionate about, to pursue it. As it ultimately becomes a part of who you are, and it's not a chore, it's not a task, it's something you love doing, and you will find a way to make it work for you. It does require hard work and commitment, and it does require sacrifices, but you make them because you know it's what you want, and it's ultimately the vision that you have for yourself and who you want to be.
You've invested a huge amount of time in school. One of the big issues people are having right now is going back to school, going back to university. Some people think that if we keep kids out of school too long, we actually harm their development long term. Do you have an opinion?
I do, in a way, from my own personal experience. My claim to fame is that I didn't actually go to all of high school. My family immigrated and left Iran during the time that I was in high school, and so I worked for a period of that in London, England, and then we came to Winnipeg, Manitoba after we immigrated. So missing school is not going to be detrimental. You'll make up for it. There'll be ways we can find to supplement the education and the experience. I think what you miss really is the social interactions at school that can't be replaced. But the educational components, I think people can catch up with. I don't think it's a major detriment, but I'm not an educational expert, so I don't want people in the education field to be upset with me. But I do think our safety, our health, well-being is a primary goal. And I think we'll all get through this. Whether it is to have a period of time where school is closed, I think we'll all be able to make up for it.
Dr. Zadeh, the newly appointed first female Dan Chair of Neurosurgery at the University of Toronto, professor at University of Toronto, and head of the Division of Surgical Oncology at the Department of Surgery at UHN. Thank you so much for joining us tonight, and congratulations again.
My pleasure, and thank you very much for having me do this interview with you. It's a very good experience speaking to you. Thank you very much.
Our honor. Good night, everybody.